Okay, so starting with Marfan syndrome, it's a disorder of connective tissues manifested principally by changes in the skeleton, eyes, and cardiovascular system. So it is because of the defect in a glycoprotein which is fibrillin 1. Okay, now there's a loss of a structural support in the microfibril rich connective tissue or excessive activation of the transforming growth factor or TGF. So this is important. This is important. Now, what is the mechanism? So we know that fibrillin is a major component of the microfibrils which is found in the extracellular matrix, and these fibrils provide a scaffold on which tropoelastin is deposited to form elastic fibers, which is abundantly present in the aorta, ligaments, ciliary zonules that support the lens. And all these tissues are affected, therefore, in the Marfan syndrome. There are two forms of fibrillin 1 and 2, which are encoded by genes FBN1 and FBN2 mapped on chromosome number this, and the mutations which is there in FBN1 underline Marfan syndrome, and the FBN2 genes are less common, and they give rise to something else called congenital contractural arachnodactyly, an autosomal dominant disorder characterized by skeletal abnormalities. Okay, all these are points. There is no concept here. Okay, this is just, you have to memorize these points, and all of these can come as short note, can come in your MCQs, can come as long questions. So all of these are important, but there is no concept. Most of these are missense mutations, especially in the fibrillin 1, and this can inhibit the polymerization of fibrillin fibers, and therefore there is a reduction in the fibrillin content below a certain threshold, which weakens the connective tissue. So basically the connective tissues of all these locations are defective. Now what is the mechanism behind the TGF beta bioavailability? So what happens is that normally what happens, if the fibrillin is normal, that usually inhibits the TGF beta formation. Okay, but when the fibrillin here is not normal or abnormal, therefore the TGF beta is increasing because there is no feedback mechanism. Okay, so see, there is bone overgrowth and myxoid changes in the mitral valves which cannot be attributed to the changes in tissue elasticity. So these features that we see have to be explained by the TGF beta bioavailability. It is established that fibrillin 1 controls the bioavailability of TGF beta. Reduced or altered form of fibrillin 1 which is present here, that will give rise to abnormal and excessive activation of TGF beta. Very, very important question. Since the normal microfibrils, they sequester TGF. So if the fibrillin is normal, it will sequester, it will inhibit the TGF. But since here it is not functioning normally, it is abnormal here, therefore there's going to be an excessive activation of TGF beta, and this excessive TGF beta will now lead to inflammation, has deleterious effects on vascular smooth muscle development, and increases the activity of metalloprotease, which cause the loss of extracellular matrix. There is gain of function mutations in the TGF beta type 2 receptor, which gives rise to a related syndrome called as Marfan syndrome type 2. So this is again an important point. Patients with germline mutations in one isoform called as TGF beta 3, which presents with an inherited disposition to aortic aneurysms and cardiovascular manifestations found in these patients. All these are important points. There is also angiotensin receptor 2 blockers which inhibit the TGF beta activity. They markedly reduce aortic root diameter, and therefore this is under the clinical trial. So angiotensin receptor 2 blockers can be used. So this is under clinical trial because it inhibits the TGF beta activity, and this is what is required here because TGF beta is getting proliferated and there's an excessive activation of TGF beta here. So angiotensin receptor 2 blockers can play some role here. Now this morphology is very, very important. All these points, you have highlighted almost the entire page. All these points are important. I cannot miss out on any of these points. There is no concept here again explaining, but then these points are something that you cannot miss out on. So let's read this now. Skeletal abnormalities are the most striking feature of Marfan syndrome. The patient is unusually tall with exceptionally long extremities and long tapering fingers and toes. The joint ligaments are lax, suggesting that the patient is double jointed. Typically, the thumb can be hyperextended back to the wrist. The head is dolichocephalic with bossing of the frontal eminence and prominent supraorbital ridge. Spinal deformities are there like kyphosis, scoliosis, rotation, or slipping of the dorsal or lumbar vertebra. The chest is Classically deformed, presenting with either the pectus excavatum, which is the depressed sternum, or a pigeon breast deformity. Ocular changes are there. The most characteristic changes is the bilateral subluxation or dislocation, usually outward and upward. Very, very important point. Upward and outward, known as the ectopia lentis. This abnormality, because of the weakening of the ciliary zones, is uncommon in persons who do not have this disease. The finding of bilateral ectopia lentis should raise the suspicion of Marfan syndrome. This is a very important, very, very important point. Cardiovascular lesions are the most life-threatening features. Again, very, very important point. The two most common lesions are the mitral valve prolapse, very important, which occurs in 50% of the patients, and also there is dilatation of the ascending aorta due to cystic media necrosis. Histologically, the changes in the media are virtually identical to those found in cystic medial necrosis, not related to Marfan syndrome. Loss of medial support results in progressive dilation of the aortic valve ring and the root of the aorta, giving rise to severe aortic incompetence. Important point: aortic incompetence and mitral valve prolapse are the two points, and obviously this gives rise to aortic dissection. Very, very important. So aortic dissection and mitral valve prolapse are the 2 points that you need to remember here. Now, mitral valve lesions are more frequent, but they are less important than the aortic lesions. Loss of connective tissue support in the mitral valve leaflets make them soft and billowy, creating a fluffy valve. These vascular lesions, along with the lengthening of the chordae tendineae, gives rise to mitral regurgitation. Important. And similarly, the tricuspid and the aortic valves are also affected, and the echocardiography can enhance the ability to detect these cardiovascular abnormalities. The deaths usually occur because of rupture of the aortic dissections, and which is followed by cardiac failure. Now, because of all these variations of the clinical presentation, the diagnosis is based on something called as the revised Ghent criteria. This takes into account the family history, number one, cardinal clinical signs in the absence of family history, number two, presence or absence of fibrillin mutation, number three. So there can be family history, number one, there can be absence of family history, but then the cardinal clinical signs have to be present, number two criteria. Number three is presence or absence of fibrillin mutation, number three. So in general, the major involvement of two of the four organ systems, skeletal, cardiovascular, ocular, and skin, and minor involvement of other organ is required for diagnosis. So the variable expression can be explained by the fact that there are so many different mutations. There can be up to 1,000 mutations in the fibrillin locus, which gives rise to so many various kinds of clinical symptoms happening in these patients. Next important disease is the Ehlers-Danlos syndrome. It comprises a clinically and genetically heterogeneous group of disorders resulting from some mutations in the genes that encode collagen, enzymes and modify collagen, and less commonly other proteins present in the extracellular matrix. So here the collagen is affected. Okay. The other disorders that happen because of the mutations from collagen are the osteogenesis imperfecta, Alport syndrome, and epidermolysis bullosa. All these three also happen because of defect in the collagen, including this EDS syndrome. Now you know that the biosynthesis of collagen is a complex process. What usually happens is the tissues which is rich in collagen, like skin, ligaments and joints, they are frequently involved. The abnormal collagen, they lack the tensile strength, and therefore the skin is hyperextensible, the joints are hypermobile, and these features permit the grotesque contortions such as bending of the thumb backward to touch the forearm and bending of the knee forward to create almost at a right angle. Okay, the skin is extraordinarily stretchable, extremely fragile and easily bruised. Also important point, please don't confuse between the Marfan syndrome and this syndrome. So those, you may get some features which are overlapping, but then please keep this in mind. The basic defect in connective tissue may lead to serious internal complications like the rupture of the colon and the large arteries present in the vascular EDS, ocular fragility with rupture of the cornea and retinal detachment seen in the kyphoscoliosis type, and the diaphragmatic hernia seen in the EDS type. So you see this chart, again a very, very important chart. There are so many types of EDS. Classic type, which is 1 and 2, hypermobility is type 3, vascular is type 4, kyphoscoliosis is type 6, and arthrochalasia is type 7, and dermatosparaxis is type 7C. So you can see that all of these are autosomal dominant except the kyphoscoliosis type and the dermatosparaxis type. These two are autosomal recessive, except the all others are autosomal dominant. These genes are very, very important. Classic involves the COL5A and COL5A2 gene. only the hypermobility type, the defect is unknown. The others, the defect is known. Only in this case, the defect is unknown. Okay, here in the vascular type, the gene involved is called 3A1. Here in kyphoscoliosis type, the lysyl hydroxylase enzyme is defective. These genes, all these are very, very important points. The clinical findings are also summarized here, and you must read this. Okay, so as I mentioned that in the hypermobility type, the gene defect is not known, and in the kyphoscoliosis type, this is the autosomal recessive type. It results from mutation in the plot1 gene. Important point. So kyphoscoliosis type में lysyl hydroxylase enzyme is defective. The gene is plot1. This enzyme is necessary for hydroxylation of the lysine residues in the collagen synthesis, and therefore when this is defective, the collagen synthesis is defective. The affected patients have markedly reduced levels of this enzyme, and because this enzyme, because the hydroxyl lysine is essential for the intermolecular and intramolecular cross-linking of the collagen, and therefore the deficiency of this enzyme results in the synthesis of collagen, which lacks the structural stability. Okay, now vascular type results from the abnormalities of type 3 collagen. Very, very important point. Which collagen? Type 3 collagen, and therefore the gene involved is called 3A1 gene. So the collagen is type 3, therefore the gene is called 3A1 gene. So all these points are described here. Essentially, you need to remember this. This will be coming as your questions. You won't be able to write this much in your exam, so this chart should be in your fingertips. And then the next point is that if you talk about the dermatosparaxis type, the gene involved here is ADAMTS2. Again, these two are very, very much interlinked. This is again an important question. The ADAMTS2 gene is involved in dermatosparaxis type, and in the classical type, the call 5 or the type 5 collagen is involved. Very, very important. So don't make a mistake here that in the classic type it is the type 5 collagen involved, and in the vascular type it is the type 3 collagen involved. In the arthrochalasia type it is the type 1 which is involved, and in the dermatosparaxis type it is the ADAMTS2 gene which is involved. Okay, so from this gene only you can understand which are the collagen type which is involved. Okay, यहाँ पर 5 involved है, 3 involved है, यहाँ पर 1 involved है. So this is it. And coming to the lysosomal storage diseases, again an important point. We know that lysosomes, what they do is that they break down the complex macromolecules, right? So these macromolecules which are broken down, they are derived from the intracellular organelles. Okay, the mechanism is autophagy, and they may be also acquired from the outside. When they are destroyed, the process is heterophagy. Now obviously lysosomes, they are the key components of intracellular digestive system. Basically what happens is they have the enzymes which are the lysosomal enzymes of the acid hydrolysis. They are synthesized in the endoplasmic reticulum, and then they are transported to the Golgi apparatus, where they undergo post-translation modifications, including the attachment of terminal mannose 6-phosphate. And these lysosomal enzymes, now they bind with the receptors, and they are segregated from the numerous other secretory proteins within the Golgi. These transport vesicles containing this receptor-bound enzymes are pinched off from the Golgi, and they proceed to fuse with the lysosomes, and ultimately there is breakdown of this complex macromolecules with the help of these enzymes. But whenever this sorting mechanism is not proper, then that gives rise to something called lysosomal storage diseases. And therefore and you must know that there is a link between the lysosomal storage diseases with the neurodegenerative disorder. Why there is a link between the lysosomal storage diseases with the neurodegenerative disorder is explained in the next page, but this is an important point that you need to keep in mind. So how this actually takes place is that catabolism of the substrate of the missing enzyme remains incomplete. So whenever the catabolism of the substrate is incomplete, there is accumulation of this, and stuffed with the incompletely digested macromolecules, the lysosome becomes large and numerous. So basically the lysosomes are not able to break down those macromolecules, and now they're getting accumulated within the lysosomes. So these lysosomes are becoming large and numerous, and they enough to interfere with the normal cell function. So there's a tight linkage between the autophagy, mitochondrial functions, and the lysosome. As you know that autophagy is essential for the turnover of mitochondria by a process called as mitophagy. So mitochondria also should not keep accumulating. They also need to undergo the process of autophagy. But again, because of this lysosomal storage disorders, these mitochondria, they are not getting destroyed. And now this mitochondria is becoming dysfunctional, and because of this accumulation of the undigested macromolecules, the rate at which the lysosomes process the organelles delivered by autophagocytic vacuoles is now reduced, and therefore there is persistence of this dysfunctional and leaky mitochondria with poor calcium buffering capacity and altered membrane potential. So basically this mitochondria, this dysfunctional mitochondria is actually accumulating within the cell because they are not able to digest, they're not able to break down those those organelles, and because of that these dysfunctional mitochondria and this leaky mitochondria, they're having poor calcium buffering capacity and membrane potential, and therefore this damaged mitochondria is now also generating free radicals and releasing molecules that trigger the process of apoptosis. Now, so this impaired autophagy, this gives rise to secondary accumulation of autophagic substrate including ubiquitinated and aggregate prone polypeptides such as the alpha-synuclein and Huntington protein. So because of this impaired autophagy, because the cell is not able to digest its content, and because of the accumulation of autophagic substrate, there is ultimately accumulation of alpha-synuclein and Huntington protein, and this is why these lysosomal storage diseases are related with neurodegenerative disorders, and you know that these are getting accumulated in the neurodegenerative disorders. So therefore this is why there's a link, a very very important point. So here you must remember that an important genetic risk for developing Parkinson's disease is Gaucher's disease. Okay, so Gaucher's disease and Parkinson's disease is interconnected. Very very important point. I would like to highlight that virtually all patients with Gaucher's disease develop Parkinson's disease. A very very important point. And another important point is that if you talk about the Niemann-Pick disease, the Niemann-Pick disease type C is that increases the risk for Alzheimer's disease. Again, a very important point. So these two are interrelated. The Gaucher's disease is interrelated with Parkinson's disease, and Niemann-Pick type C is interconnected with the Alzheimer's disease. So these are interrelated diseases, and you know the basis also now, right? So these are the functions of lysosomes, but now they're not able to function them properly. If you talk about this diagram, see, basically whenever there is lysosomal enzyme deficiency, this complex substrate is now not getting digested, and therefore they are stored in the lysosome. There is stored non-metabolized products. This is the primary storage, and because of this there is defective fusion of autophagosome with the lysosome. There is defective degradation of the intracellular organelles, and now this intracellular organelles is also getting accumulated along with the complex macromolecules. This is the secondary storage, because of which there is accumulation of the aberrant or dysfunctional mitochondria, there is accumulation of toxic proteins, ultimately all of which leads to cell death because of generation of free radicals and cell damage. These are the examples which you can read, like the brain is rich in gangliosides, and therefore defective hydrolysis of these gangliosides result in accumulation of GM1 and GM2 gangliosidosis, which results primarily in accumulation within the neurons and consequent neurologic symptoms, because this is the basis why there are so many neurological symptoms in this kind of diseases. Okay, this also forms the basis of other diseases like glycogenosis, sphingolipidosis, mucopolysaccharidosis. Basically all of this is because of the accumulation of these products, because of the defect in an enzyme which is not able to degrade those substrates properly. So this again a very very important chart. All the enzyme deficiencies and the metabolites which are accumulated are mentioned here. If you talk about the sphingolipidosis in the GM1 gangliosidosis, there are two types. Type 1 is the infantile, type 2 is the juvenile. This is the enzyme which is deficient, and GM1 is accumulated. Okay, remember these three are the GM2 gangliosidosis. Okay, Tay-Sachs-Sandhoff's and this GM2 gangliosidosis variant AB. All of this is, in all of this the GM2 ganglioside is getting accumulated, and the enzymes involved are these. Similarly, in the sulfatidosis, the metachromatic leukodystrophy, this is the enzyme involved, this is the metabolite accumulated, and all of this you must remember. You see all the names are given, and the enzyme name is also given which is defective, and because of which the substrate which is the metabolite which is accumulated, that is also written. So this is a very very important chart. Okay, you can see in the Krabbe's disease there is deficiency of the galactosyl ceramidase which leads to accumulation of galactocerebroside. Fabry's disease, alpha galactosidase A leads to accumulation of ceramide trihexoside. Gaucher disease, glucose cerebrosidase, because of which is accumulation of glucose cerebroside. Niemann-Pick disease is there is defect in the sphingomyelinase, because of which sphingomyelin is getting accumulated in the mucopolysaccharidosis, which is the Hurler-Hunter syndrome. You know, in the Hurler you have the alpha L iduronate enzyme defective, and in the Hunter syndrome you have the iduronate 2 sulfatase enzyme which is defective. See, these are very, you know, confusing terms. So this is again a very important chart. You must remember all of this. It's a last minute revision chart. All the enzymes, the metabolites, all this, there's nothing much to understand, because you will read these mechanisms in biochemistry in details, and therefore this is going to be your last minute revision chart. You can just go through it once. You can see here also it is mentioned about the Tay-Sachs disease. This is a GM2 gangliosidosis, as we have learned here. See, Tay-Sachs disease is basically a GM2 gangliosidosis because of the deficiency of the hexoaminidase alpha subunit deficiency, which leads to accumulation of GM2 gangliosidosis, right? Now, yes, this part is important. So this hexoaminidase A is basically absent from all the tissues. So basically this accumulation of GM2 ganglioside in almost all the tissues. The involvement of neurons in the central and autonomic nervous systems and retina dominates the clinical picture. Very important. These systems are mostly involved in this disease. What happens is the neurons are ballooned with cytoplasmic vacuoles representing a markedly distended lysozyme. In the electron microscopy, you can see cytoplasmic inclusions, okay, which are the whorled configurations composed of onion skin layer membranes. The ganglion cells in the retina are similarly swollen with the GM2 ganglioside. Cherry red spot is appearing in the macula. Very important point. Niemann-Pick disease also same thing. There is accumulation of the sphingomyelin because of deficiency of sphingomyelinase. The type A is a severe infantile form with extensive neurologic involvement, marked visual accumulation of sphingomyelin, progressive wasting, and early death. Whereas in type B, they have organomegaly, but there is no central nervous system involvement. Very important. In the type B, there is no central nervous system involvement. This is the chromosome which is involved, especially in the maternal chromosome. This is involved, and this is typically inherited as autosomal recessive. Okay, as you can see here, that this is the electron microscopy picture where you can see the whole configurations of the lysosomes, and here you can see that this is a neuron, but it has got this lipid vacuolation. So you can see this is basically the ganglion cell in the Tay-Sachs disease. So the classical infantile type A, this missense mutation will lead to accumulation of sphingomyelin because of deficiency of sphingomyelinase, and you can see the affected cell becomes enlarged, sometimes up to 90 micrometer in diameter due to distension of the lysosomes with sphingomyelin and cholesterol. Electron microscopy mein you will see zebra bodies here. Very important question. The lipid little phagocytic foam cells are widely distributed in all over the places. The involvement of the spleen generally produces massive enlargement. Very important point. There's vacuolation and ballooning of the neurons. Very important point. Retinal cherry red spot is also seen. Very important point. So whatever is marked here, you can see in bold all your last minute revision topics. Then the infants present with a protuberant abdomen because of hepatosplenomegaly. You can see this is the picture of Niemann-Pick's disease. You can see this liver cells, which are the hepatocytes, and the cover cells. They have a foamy vacuolar appearance because of the deposition of the lipids here. Type C is not that important. Type AB is more important. If you talk about the Gaucher's disease, then similarly, this is also an autosomal recessive disorder. As I've already mentioned, that the inborn error of metabolism, they essentially have the autosomal recessive inheritance. So the Gaucher's disease results from mutations in the gene encoding the glucose cerebrosidase, because of which this accumulation of glucose cerebrosides, especially in the central nervous system. There's activation of the macrophage and the consequent secretion of the cytokines, which cause the destruction. The most common form is the type 1 or the chronic non-neuropathic form, in which the accumulation is limited to the mononuclear phagocyte system, but there is no involvement of the brain. Very important. The spleen and the skeletal involvement dominates this pattern. There is no CNS involvement. It is present in the juice. Okay, but type 2 is basically the neuropathic type, which is the infantile acute cerebral pattern. This has got no predilection for the juice. Very important. This had got predilection for the juice, this has a no predilection for the juice. Here the brain or the CNS is mostly affected, and you can see that there is no detectable glucose cerebroside activities in this tissue. Hepatosplenomegaly is also seen in this form of Gaucher's disease, but the clinical picture is dominated by progressive central nervous system involvement leading to death. So here the phagocyte system or the spleen, liver, these are mainly involved, but here the CNS is mainly involved. You also have a third pattern which have intermediate features between this. Okay. Now, if you talk about the glucocerebrocytes, they accumulate in the massive amounts within the phagocytic cells of the body. These distended phagocytic cells, known as the Gaucher cells, they are found in the spleen, liver, bone marrow, lymph nodes, tonsil, thymus, Pierce patches. Gaucher cells, they rarely appear vacuolated, but they have a fibrillary type of cytoplasm which is linked to a crumbled tissue paper. And yes, they are very big and they have extrinsically placed nuclear. The periodic acid shift staining is usually intensely positive. Important point with the electron microscope. You can see this fibrillary cytoplasm which can be resolved as elongated distended lysosomes. So you can see this is the crumpled tissue paper appearance. The first one is the right stain and this one is the H&E stain. In the type 1, obviously the spleen is enlarged, as I mentioned that here the phagocytic system is involved, the lymphadenopathy is present here, and it also produces a bone erosion leading, that are sometimes there, which is sufficiently large to cause pathologic fractures. The bone destruction occurs due to secretion of cytokines by the activated macrophages. In patients with cerebral involvement, the Gaucher cells are seen in the virtual Robbins spaces and the arterioles, which is surrounded by swollen adventitial cells. This is a very, very important point. The mutation of the glucocerebrosidase gene is the most common known genetic risk factor for development of Parkinson's disease. So again, this is related to Parkinson's disease. As I said, that Gaucher's disease is related to Parkinson's disease. So when you see this kind of connection in the question, don't get surprised, because glucocerebrosidase gene is also involved in Parkinson's disease, and therefore there's a reciprocal relationship between the level of this enzyme and the aggregation of alpha-synuclein, which is involved in the pathogenesis of Parkinson's disease. This is the basis why these two diseases are interconnected, right? Now, mucopolysaccharide, same thing. Here you must remember that all the MPS are basically inherited as autosomal recessive, except the Hunter syndrome, which is inherited as X-linked recessive. Very, very important point. Very important point for MCQ, okay? And these are the features. Iske bare mein obviously you will read details in biochemistry. These are the points I'm highlighting here, which will come for your MCQ, which are very important to remember. The accumulated mucopolysaccharides are generally found in the mononuclear phagocytic systems, endothelial cells, intimal smooth muscles, and fibroblasts throughout the body. The hepatosplenomegaly, skeletal deformities, valvular lesions, and subendothelial arterial deposits, particularly in the coronary arteries, and the lesions in the brain are the common threads that run through all the MPS. So this is basically the features that is common to all the MPS. Myocardial infarction and cardiac decompensation are the causes of death. In the Hunter syndrome, there is absence of corneal clouding. This is a very important point. That hunters, they have to see clearly, so there have to be a absence of corneal clouding in the Hunter syndrome. This is how you can remember it. Now coming to the glycogen storage diseases, obviously the pathways you're going to read in biochemistry. This is a combined pathway, but what's important here to remember is this particular chart, in which they have segregated some subgroups of these glycogenesis, which means some of these glycogenesis or these disorders that affecting the liver, some are affecting the muscle, and there are some which affects any of this. So hepatic type mein aata hai type 1, which is the most important because of deficiency of glucose 6 phosphatase, and that if the liver is affected, there's going to be hypoglycemia, very important, hyperlipidemia, hyperuricemia, bleeding tendency due to platelet dysfunction. There's hepatomegaly and renomegaly over here. But in the myopathic type, which is basically the type 5 or the McArdle's disease, because of deficiency of muscle phosphorylase, the skeletal muscle is affected and there's painful cramps associated with strenuous exercise, and myoglobinuria occurs. So you can see how the clinical features are getting different, how the patients are presenting differently based on whether it's a hepatic type or it's a myopathic type, right? And you must remember that there's something called as Pompe's disease or type 2, which is basically a lysosomal storage disease, because the enzyme deficient here is lysosomal acid alpha glucosidase. Okay, so you can see here that acid alpha glucosidase is a lysosomal enzyme, and hence its deficiency leads to lysosomal storage disease of, that is the type 2, which is the Pompe's disease in all organs, but cardiomegaly is the most prominent feature here. Very, very important. There's a massive cardiomegaly over here. Now coming to this, something called as complex multigenic disorders. I think I've already explained this before. What happens here is multifactorial. I've explained in the initial part of this chapter that there are so many other factors which play an important role in the formation of these diseases.